Good afternoon. My name is Sarah Moynihan, and I am the Social Media Research Assistant at the Institute for Neuro-Immune Medicine. I'm joined by Anna Del Alamo, Administrative Director at the Institute for Neuro-Immune Medicine at Nova Southeastern University. I would like to welcome everyone to today's webinar, Understanding ME/CFS Today, a Clinical and Research Approach, featuring the Institute's nurse practitioner, Irina Rozenfeld, physicians Dr. Maria Vera-Nunez and Dr. Irma, and Director of the Institute's Clinical Systems Biology Group, Dr. Travis Craddock. We'll be having an intermission scheduled from 1:15 to 1:45 to give everyone an opportunity to step away and relax, but we welcome you to stay if you can and view the intermission slideshow. If you notice within your control panel, there's a Q&A tab. If you have any questions, please identify to whom the question is addressed to before typing it within that section. Also, we will have a live Q&A portion at the end of this webinar, so our presenters will do their best in answering your questions. I want to thank everyone again for joining us, and I will begin by introducing the Director of the Institute for Neuro-Immune Medicine, Dr. Nancy Klimas. Dr. Klimas is the Dean of Research and Professor of Medicine at the Dr. Kiran C. Patel College of Osteopathic Medicine and Chair of the Department of Clinical Immunology at Nova Southeastern University. In partnership with the Miami Veterans Affairs Medical Center's Gulf War Illness Research Program, the INIM is a multidisciplinary research and clinical institute that takes a systems biology approach to understanding complex medical illnesses such as myalgic encephalomyelitis / chronic fatigue syndrome, or ME/CFS, and Gulf War illness, or GWI. Dr. Klimas is Professor Emerita at the University of Miami's Miller School of Medicine, a diplomat of the American Board of Internal Medicine, a diplomat in diagnostic laboratory immunology, and Director of Clinical Immunology Research at the Miami Veterans Affairs Medical Center. She has achieved national and international recognition for her research and clinical efforts in multi-symptom disorders, including ME/CFS and GWI. She is past president of the International Association for CFS and ME, and a past member of the Health and Human Services CFS Advisory Committee. Take it away, Dr. Klimas.
Okay. Hi, everybody. Thanks for joining us today. This is really exciting. It's our first time ever putting on a conference that was entirely virtual. We've had some great conferences since we developed the Institute at Nova Southeastern University, and sometimes we've had as many as 800 people on the web when we're putting on our conferences. But we've always had an audience to talk to. So let's see how we do. It's going to be kind of fun. This is, as you know, ME Awareness Month, Week, Day, and it's an important time, and it's a nice time to plan and pull off a conference. This has been in the works for, long before COVID. So this is our ability to be adaptable. Anyway, here we are, and we've put together a conference today that's just going to be great from the patient's perspective. We have very experienced clinicians who have a lot of success in treating ME/CFS as your panelists, as well as Travis Craddock, who's the key guy that ties all of our research program together, because our computational biology approach is what's been able to glue all these interdisciplinary ways of looking at this disease into a modeling approach. So I think you're going to like the whole thing. It's very, very exciting. For those of you that know a lot about our institute, where we brought a very good scientists together to develop a brand new program almost 10 years ago now at Nova Southeastern University. We've grown. We have 16 faculty members. We're about 60 people all in all dedicated to ME/CFS and Gulf War illness research and clinical care. So we have a clinical program. We have a laboratory-based research program. We have the computational program. We have translational research. We're in 3 places. We're at the Miami VA, where we do a lot of veteran-centric work, but we also have a veterans clinic at Nova that takes care of veterans with these complex illnesses, and more recently, Nova's established a primary care program for veterans care that's actually free to veterans and their families. So let people know about that. We have this great team. We're knit together. We're hell-bent on developing a cure, not just a treatment that's effective for ME/CFS. We're focused on the big game. But in the meanwhile, we're also very, very keen on applying new knowledge in the clinical area. So you're going to have some great speakers today. Your first speaker is Dr. Maria Vera-Nunez. She has a long history with ME/CFS. She did research with me back when I was at the University of Miami, and I more or less begged her to join us when we started the program at Nova, and I couldn't be more delighted that she chose to join us. She's an example of the kind of clinicians we have, because one of the things that happened at Nova when we all came together to practice is we realized that we were really practicing in an integrative medicine way. And as you'll hear from the other speakers today, one of the things you'll see in our group is that people pursue new knowledge vigorously. And you'll find that in our group that in the 9 years we've been at Nova, we have our clinicians have all added specialties on top of their specialties, either integrative medicine, functional medicine, environmental medicine, or some combination of those. So everyone's added some extra board certifications since they've been working here. So Dr. Vera is no exception. She is a physician scientist at the Institute for Neuro-Immune Medicine. She's a faculty member in the College of Osteopathic Medicine at Nova. She's a diplomat of the American Board of Internal Medicine, Integrative Medicine, and is a certified functional medicine practitioner. Hear all those boards? That's pretty amazing. She recently earned her Master's of Science in Biomedical Informatics. She's worked in research and in clinical care for patients with ME/CFS and other multi-symptom complex disorders since 2008. She uses an integrative and functional medicine approach in her evaluation and management of patients with chronic inflammation and immune dysfunction, and she's a member of the US ME/CFS Clinicians Coalition. Dr. Vera's research interest is focused on the role of immunomodulators and chronic inflammation pathways to recognize therapeutic targets and management options for patients with complex chronic conditions. She's also interested in the development of tools and applications of information technology to improve the education and care of patients with chronic conditions. Dr. Vera is a lifelong learner and continues attending conferences and workshops to gain more tools for the treatment of her patients. That hardly begins to say what an amazing doctor and what an amazing person Dr. Vera is. And I'm very pleased to introduce her as your first speaker in this conference.
Thank you very much, Dr. Klimas. The topic I will discuss today is the integrative and functional medicine approach to myalgic encephalomyelitis and chronic fatigue syndrome. We start with evaluating why ME/CFS is a complex condition. We know that it's challenging to evaluate and to treat patients who have this condition. And one of the reasons is because when a patient receives this diagnosis is because they have multiple symptoms. The main one are severe fatigue that is unexplained, that lasts more than 6 months, and also post-exertional malaise. But in addition to that, the patient may present some issues with sleep or diffuse muscle or joint pain, cognitive problems, issues with blood pressure, heart rate regulation, multiple infections or other signs of immune dysfunction, gastrointestinal symptoms, and many others. And sometimes it's a combination of all of these, sometimes only a few. But these indicate that the patients, there are multiple systems affected on these patients. Another challenge is that multiple times there would be different triggers to start this condition. Some patients will recall that after having an infection, that's when their symptoms started, and it could be with parasites or bacteria or viruses, or others may have had exposure to toxins or certain medication drug interactions, also could be traumatic events, physical trauma, like an accident, or having a complicated surgery that they never recover after, or psychological trauma as well. Chronic stress could be also a factor. Sometimes symptoms could start after a patient had a major life change, maybe moving or losing a job or changing jobs or getting married, getting divorced. And multiple times we will have a combination of all these factors that may not be just the one thing, but may have had more of these happening at the same time. And also because the degree of disability in our patients may vary. Some may have some mild changes, but some of them may have severe changes. And sometimes patients may not look that ill. Patients, family members, or providers, healthcare evaluations, they won't understand the degree of impairment that our patients have. So once a patient has the diagnosis of chronic fatigue syndrome, myalgic encephalomyelitis, they will go and have an evaluation with a conventional approach. A usual evaluation for our patients indicate, I like this example from this Indian story where they brought a group of blind men into a room and they showed them an elephant and they wanted to describe what the elephant was. Each one of them only could touch parts of it and they will only have one piece of information, so they will have different reactions and different concepts. Something similar happens with our patients. When they go to have evaluation by different specialists, they will have a specific diagnosis. So for example, if our patient goes to a gastroenterologist, they may come out with a diagnosis of irritable bowel syndrome or small intestinal bacterial overgrowth, or they may have some autoimmune diagnosis, some autoimmune markers that may be not as clear. They may not fit the criteria for a regular rheumatological condition. They may have sometimes they will also go to some evaluation and the answer would be that nothing is wrong with them, that all the results and tests were normal. So as you can see, the approach is a little fragmented. Patients may receive different diagnoses, and for each one of them, they may receive different treatments, different medications. Sometimes they may be helpful, but sometimes, most of the time, the major symptoms won't change and the patients will continue to be impaired. So what else can we do to evaluate our patients and go a little deeper? To start with, the integrative medicine approach will acknowledge the complexity that a person has. It will look into all the factors that can influence health, wellness, and disease in the patient. And for example, we'll evaluate not only body, but also what is happening in their minds, what connections, community they still have, and how it can affect their health, as well as their own spiritual, religious beliefs. Integrative medicine acknowledges that the person is a whole, so it will look into what's happening on the life and the behavior that the patient has. Will not only acknowledge the patient's symptom, but will look into how the connection between the mind and the body, if they have any spiritual belief or practices. Also, if they are moving or having some kind of activity or exercise, how is their nutrition, if they are able to receive the right kind of nutrients. The environment, how is their connection with earth, not just all the possible exposure to toxins and other chemicals in our environment, but also their connection with nature. If the patient is able to sleep and rest and have a restful sleep, how connected are they with their family, their friends, their community. And all those factors are taken into account when evaluating and treating the patient. You're also looking into prevention, how you can help patients to modify their behavior so they are less susceptible to disease. Besides that, there's also the importance of the partnership between the healthcare provider and the patient. This is a crucial step where the providers like to empower patients so they can take care, they can modify their behavior, understand why they are making the changes that they're making, and have an impact on their health. So it's very important that partnership between the provider and the patient, which is crucial for this kind of approach. So basically, as we said, with the integrative medicine approach, you are looking into all the factors that can affect a patient's health and if they are sick as well. And it's very open in terms of the management. So you will see here, this graphic is taken from Dr. Reichel's book in Integrative Medicine. And you see here pharmaceuticals. So that is very important to understand because sometimes some people believe that integrative medicine will not use medications or conventional medicine. In this case, the idea is to use any tool or any intervention that will help your patient and will cause the least amount of damage or side effects. So you could use medications. Sometimes you need to, if you have an infection or some acute event where you need to have a response, then you may use that. You may need to use surgery as well if it's needed. But also it will open up to see what other tools do we have to treat our patients. So we have option to use some other herbs or some other supplements, the use of manual medicine, also mindfulness practice, meditation, some other mind-body therapies, and the importance on how our diet and our food will affect our health. We'll use also the impact of research and some other connections in the community. So the integrative medicine approach looks for opening up and using any tool that can help our patient, and which, as I said, is the least troublesome and the one that is most effective. When you are looking in that in this approach, sometimes you may still follow a little the conventional medicine approach, because sometimes if the patient has pain or inflammation, you may use certain supplements specifically to treat those symptoms. One important step, going a little deeper, is the functional medicine approach. With functional medicine, you will still use all the tools that integrative medicine provides, but it's a way to organize the information that your patient has. So when we have a patient with any CFS, we will find that they have multiple systems in the body that are affected, and they will have also multiple symptoms. When you are evaluating a patient with the functional approach, you going to look into the timeline. Here, your doctor will be a detective, because we are looking into what factors can affect or have lead you to be sick. We start with antecedents, which is what happened even before you were born. What family history do you have? That's where genetics comes in. If your family had a history of an autoimmune condition, or maybe they had a lot of cardiovascular problems, or cancer and some other conditions. Multiple times our patients will have some family member who also has a diagnosis of ME/CFS, or they had a weird rheumatological condition that they couldn't diagnose. So those are predisposing factors. Also, what happened when you were born? When you were in the womb, during the pregnancy, was your mom okay? There was any complication? Did they have any surgeries, any treatments? Were you born premature, on time? Was it a C-section? Were they able to give you breastfeeding? All those factors will affect either your immune system, the type of bacteria you have in your gut, and will, in a way, give you a higher risk for other conditions in the future. The second thing that we look into the timeline, thinking that this is your life timeline, are different triggers that may have happened even before you got sick. So if at some point maybe you had an accident, a motor vehicle accident, some bone fracture, or you were undergoing a lot of stress in a period of your life, as we described before, life changes like losing a job or moving or getting married or divorced, or if you recall, maybe you had mononucleosis or EBV when you were in high school, or some other infection, and maybe you had a lot of respiratory infections when you were a child and you needed antibiotics frequently. If you had, again, physical or mental trauma, or maybe you lived in a farm and then they sprayed pesticides frequently, or you had other kind of toxic exposure throughout your life. All those points in your life where something happened, it will affect the balance on the way that your body works. So usually some of the patients will definitely have a clear cut point when things started, when they felt tired and they did not recover, but also several times it would be very slowly progressing, and usually would be each one of these factors that are happening that will tip the balance of your body until you get a final blow when the scale tips over and then your body is not able to recover and does not go back to normal function. So it's very important to evaluate all these factors. And finally, the mediators. So mediators are factors that after you already got sick, you got your diagnosis, what is happening now that keeps your body being sick? So there are other factors as well, maybe similar to the ones before, but for example, if you are not able to cook, you are too tired, and then you're eating fast food or sodas every day, that you may not get the right amount of nutrients, and the kind of food that you're eating may cause some inflammation, not just in the immune system in your gut, but in the rest of your body. You may still be exposed to toxins if you're maybe living in a house that has mold growth and you're sensitive to it. And if you're having chronic stress, maybe just by being sick, or maybe that you're not able to connect with your family or your friends as before. So all those factors that are still there will maintain and keep the imbalance happening in the body. So going back to this graphic with what describes the functional medicine approach, the way that I see it is that for functional medicine is mostly a way how you organize that knowledge that your patient gives you, not just because of the information that you collect with the history and the evaluation on your physical exam, but also with some of the tests that maybe have to be specialty tests, because as we said, most of the time regular lab tests will be normal, but some other tests may identify which systems have been affected and how affected they are and how we can help to regain balance. So after you collect information from the history, from what happened in your past, what symptoms you're having now, and collect as well maybe your genes and some other predisposing factors, you put it all together and you evaluate what systems have been affected. So that's where systems biology comes in. We're looking to find what is the underlying mechanism. What we have here is a representation of different networks, and it's very complex because a patient would be part of a social network, family, friends, community, country, earth, and all the exposure that happens on the environment. And then you identify here, we see like disease, like you may have multiple diagnoses, as I said, maybe fibromyalgia, maybe irritable bowel syndrome, dysautonomia, and you see how the conditions are connected because the systems, the body systems and the organs that cause those symptoms are connected as well. And what you want to do is once you identify that, you want to go even a little further and identify at the metabolic or cellular level what processes are being affected. So for example, if we have a patient who has met the criteria for ME/CFS and gets these frequent flu-like symptoms with sore throat, lymph node inflammation, feverish, malaise that comes and goes, gets worse after they exercise, And when we are evaluating the patient, we identify that the patient has an immune dysfunction with, let's say, mononucleosis or EBV reactivation. So the virus is causing all these immune problems. And maybe the patient also will have decreased blood pressure. The heart rate goes up very fast when they're trying to move around, and they get tested and they have this dysautonomia diagnosis. So you want to go, and then when you keep testing, and then you find that, oh, this patient has some changes in the mitochondrial function, and that it will be an important information, because you know that mitochondria is a part of your cell that produces energy, and that will give, and it's present in most of the cells in your body and will allow the cells to do their job. So if your mitochondria is not working properly, that immune cell won't have enough energy to deal with the viruses. And that viral infection may be one of the factors for the dysautonomia, because EBV may affect some of the nerves that have to do with the control of the heart rate and the blood pressure. So that would be one thing. But then when you explore a little further, then you realize that this patient was exposed, was living in a house that was moldy. And when you do the evaluation, you identify that this patient was in fact exposed to mold. And you know that mycotoxins will affect the function of mitochondria. So when you have all that information, what you want to do is, where it comes the personalized approach for that functional medicine does, is that when you gather all this information, then you have to prioritize what will be your first therapy. So if you start with this patient, if you use antivirals, they may tolerate, they may actually have also side effects from it, but you're not really solving that baseline or that root cause. So you will discuss with the patient and decide what will be the most important step. And in this case, it could be that you start working on eliminating the toxin from their system. So then the consequence will be that mitochondria will work better, and that immune function will also improve. And then you can retest and decide if it's really necessary to use an antiviral. Sometimes it's not. So the functional medicine approach will do that, will collect the information, help you prioritize, and make a personalized treatment, which is crucial because our patients are not the same. They will all have their own different triggers, different mediators, and we want to make sure that we are treating the patient individually. This last part is where the integrative medicine and functional medicine come together, because you see here, this is the foundation. These are the roots for this whole tree. All these are lifestyle factors that we discussed, that integrative medicine is very helpful to help us organizing, recognizing where we can help, and also evaluating and understanding that this is the foundation for any therapy. Because even if we use the most expensive supplement or the most expensive medication, if you don't manage and work on these foundation lifestyle factors, then you may have some improvement, but a lot of patients may relapse and may have changes again and again and again. So working on having good quality sleep, some kind of movement, good nutrient intake, managing stress, and working on connection, having some relationship, feeling that you're part of a community, all that will impact your life as well. And finally, what I envision for the future, or what can be helpful to keep advancing the knowledge and the therapies in both integrative and functional medicine. We have research. This is super important because research already has given a lot of information in terms of the tests that we can do, not only for therapy, but also to keep advancing science in ME/CFS. Also technology. Now we have a clear advance in the use of technology in healthcare. An example has been the use, for example, telemedicine and telehealth, especially during this crucial time. That could be a very valuable resource for our patients, will allow to care patients without them having to spend their valuable energy going to a clinic or a doctor's appointment. And also the multiple trackers that are coming out right now. Now you can track your activity, you can track your heart rate, your sleep quality, your stress levels. There's so many important information and data coming from those sources. So we need to capitalize and use that to help the treatment and management of our patients. And finally, education, because that is also a pillar that all the work that we are doing, we need to transmit that to healthcare students and other providers as well. The world is growing and things are opening up. There's more acceptance of these practices as well. As long as we use whatever knowledge or treatments we use are based on science and research, other colleagues are open to listen. So the main message here is that we can advance these fields using these three tools: research, technology, and education. The most important thing is to always have into account that all this care, the patient is in the center. So everything that we do is not just to say, oh, we made a good discovery. It's to say we are improving the quality and the quality of life and the health of our patients. Thank you.
Thank you, Dr. Vera. That was very fascinating. I think our attendees will find it informative. Next, I would like to introduce Dr. Irma Ray. Dr. Ray is a physician at the Institute for Neuro-Immune Medicine and assistant professor for the College of Osteopathic Medicine at Nova Southeastern University. Dr. Ray is board certified in internal medicine and environmental medicine, primarily treating patients with immune deficiencies such as chronic fatigue syndrome. She is a continuing medical education chair of the American Board of Environmental Medicine, immediate past president of the American Academy of Environmental Medicine, and board member of the American Board of Environmental Medicine. Dr. Ray specializes in mold, environmental toxins, genetic medicine, and the microbiome. So I will now hand it over to Dr. Irma Ray.
So I would like to, first of all, welcome you. I saw that there are about 147 people that are watching, and we really appreciate you being here in this time of COVID and all the stress that comes with it. So I would like to go over an environmental approach to CFS-ME, and I'm very grateful that Dr. Vera brought up environmental factors in her lecture, which was amazing. It's hard to follow up such a well-prepared presenter, but I'll do my best. So in 2014, we went to our first environmental medicine, American Academy of Environmental Medicine conference. And the first conference was on mold and mycotoxins, mold toxins. And I was blown away by the fact that the presenters were describing our patients. So immediately before, I just thought that mold was something that we all had to live with. And I didn't realize that some patients and some people were more impacted than others. So since then, I've attended probably 10 more 4 to 5 day courses on environmental causes and continue to read extensively on different environmental causes of disease. And I believe that this is a large portion of the total body toxic load, as the environmentalists call it, of our patients. I think this sets up our patients to develop immune dysfunction and sets them up to have all the different comorbidities, including fibromyalgia, autonomic dysfunction, and so on. So first, I need to let you know that I have no relevant, no relationships at all, no financial relationships at all with any of the labs that I'm going to mention, because I'm going to mention quite a few labs and quite a few tests by name so that I can give you more information. So this is the view, the way that I view CFS-ME. In 2010, when I first started working with Dr. Klimas, I only viewed it as an immunologic and a virologic illness. So I only checked for these things. I checked for the immune system in terms of the lymphocytes, the CD4 cells, the CD8 cells, the natural killer cells, and the B cells, and the cytokines, as well as these 5 viruses which have been implicated as being part of the CFS-ME picture in many studies in the past. I also checked for the comorbidities, including the sleep disorders, which can range from REM abnormalities, which are rather common, to sleep apnea, restless leg, and plain old insomnia, which can be caused by multiple different causes, including something as simple as low magnesium levels. I also would check for endocrine abnormalities because the hypothalamic pituitary adrenal axis and also the thyroid axis and the sex hormones or sex organs are also affected by this illness. So I would screen for this. And cognitive is the main complaint of many of our patients. So memory, concentration, and thought processing are affected, and many studies, including studies done at Stanford, have shown that the area of processing, the Broca's area, have been impacted. So I usually refer patients to neurologists and neuropsychologists to get these things confirmed. And I usually check the endocrine system by checking a cortisol level and a thyroid function test, including reverse T3, reverse thyrine, if indicated. And then also, last but not least, the autonomic nervous system. So blood pressure, heart rate, and temperature become very important, because when the hypothalamus is abnormal, or you have mitochondrial dysfunction, you'll have problems with the autonomic nervous system. Okay. The level of evidence is 2, 3, and 4, what I'm presenting you, which means it's either from small studies or from direct observation or from, case reports. So there are no large studies of thousands of patients for any of these things. However, there are hundreds of practitioners throughout the United States and the world practicing environmental medicine on patients with fatiguing illnesses and having a good response to this. So let me show you my favorite way of looking at the environmental load in patients. The environmentalists call it total body toxic load, and this little barrel here is the way that Dr. Bill Ray, who passed away in 2018, and he was one of the founders of environmental medicine. And this is the way that he looked at it. And all these things are not, they're important, but most important is that we test for interleukins and tumor necrosis factor and interferons. Those are the cytokines that we test for, and they're directly affected by your total body toxic load. And they can cause pain, they can cause hypersensitivity, they can cause itching, and he listed it as number 4, but for our patients, many times it's number 1, fatigue. He also has in his book, which is called the reversibility of chronic illness caused by environmental factors. In this book, he lists the neurologic effects of the total body toxic load. And I wish I were better with a computer and with creating a PowerPoint, but he shows how the different toxins and can affect areas of the brain. And he has multiple graphs like this. I didn't want to bore you just with going through all his different barrels, listing where the different pesticides, plastics, and petroleum derivatives, styrofoam, where all those things could act on your brain and on your body. He also published his very last book that he published, that Dr. Bill Ray published, was EMF effects. And we're really being bombarded by electromagnetic forces. And there was actually an article that came out day before yesterday talking about electromagnetic forces and whether 5G, the new internet, would be a significant factor in COVID-19. So there's a lot of information in this book about EMF effects, both from power sources and from electrosmog, which means electromagnetic forces that are emitted into the air and not necessarily carried directly in a power source such as a computer or a router or our cell phones or anything else that's electronic in nature. Something else that's very important to environmental medicine is this book, An Alternative Approach to Allergies. Dr. Theron Randolph, who wrote this book, passed away in 1995. So it's been known for this long that allergies, and not necessarily allergies where you develop, on a reaction that's sudden, such as, when your throat swells or when you develop hives, but when you actually have allergies that may range anywhere from mast cell problems to something like nausea, vomiting, diarrhea, bloating, food intolerances. And there's, inside this book, there's a rotation diet that the environmentalists use, and it consists of asking patients to take stock of what they're eating. And like Dr. Vera said, even fast foods, there are ways to obtain less processed fast foods that don't contain as many additives, because what Dr. Randolph was able to show was that he could find what you were allergic to, even if it was an additive of the product that you felt you were allergic to. So he actually writes in this book about a case of a patient that was allergic to rum from one country, but not to rum from other countries. And it was because the other rums were adulterated with corn alcohol to make it less expensive. So he wasn't actually allergic to rum or to cane sugar. He was actually allergic to corn. So it involves quite a bit of detective work to be able to find out what foods someone is having sensitivities to, but all this adds to your total body toxic load, because it sets off your immune system, and it also sets off a series of dysfunctions of your cells, because if your foods are contaminated with pesticides. We even have the case recently where patients are reacting to medical cannabis, and it's not because they're reactive to the cannabis itself. It's because the cannabis has been contaminated with pesticides, or in some cases, it's even been contaminated with rat poison. So initially, when medical cannabis became legal in the state of Florida, some patients had bleeding episodes, and it's because Coumadin or warfarin is rat poison. That's where it comes from. And patients were having bleeding episodes, bleeding complications from using medical cannabis because it had been contaminated with rat poison. So this is what I've been talking to you about. Dr. Lily Chu and Dr. Montoya did a study, which was a survey, and they showed that up to 20% of patients who answered a survey that they administered stated that they were exposed to environmental toxins before developing the CFS symptoms. In our population, it seems to be higher than that. So we try to take a very thorough environmental history, and Dr. Bested, who's part of our group, and her, when she was in Canada, she and her colleagues developed a very extensive environmental survey, which I try to administer to patients so that we find out exactly everything from even from pre-birth, because it may be something is contributing to the fatiguing illness, something that the mother was exposed to. So that's how I determine what I think is the patient's total body toxic load. That's how I determine my suspicion of what their toxic load is. After that, I try to determine the risk for heavy metals, for petroleum exposures, for pesticide exposures, electromagnetic force exposures, plastic exposures, water damage buildings, or any kind of water damage. It doesn't have to be hurricane damage. It can be pipes that break and flood the home, or pipes that break and just damage the kitchen or the bathroom area and mold is growing in that area. Also dietary habits, drug exposures, including antibiotics, cigarettes and tobacco exposure, including secondhand smoke. And I also try to ascertain what their travel history is. As we're very aware of now, travel history makes a big difference in illness, and immunization exposure, because many of those immunizations contained adjuvants that might have contained heavy metals such as mercury, and also some of the immunizations may have been live viruses, so now they have a live virus that's in their body also. We used to use a lot of what they called live attenuated vaccines, and live attenuated vaccines, the way that I try to explain them is that it's a vaccine that was hit by a punch from Mike Tyson, but sometimes it's not such a great punch, and those live attenuated vaccines could cause a lot of illness. Also occupational and hobby exposure. So patients that have a hobby in either art, where they use acrylic paints, or where they use clay, if they make ceramics, they have a high exposure. And the other people that have a high exposure, not so much nowadays, because I don't think too many people develop their own pictures, but people who in the past used to study either in college, or they used to do their own amateur photography, and they used to develop their own pictures. Those chemicals are highly toxic and may be part of their CFS picture. And also a chemical sensitivity history. The reason the chemical sensitivity history is important because that the fact that we're sensitive to a chemical usually implies that we have a lot of that chemical or chemicals similar to it inside our bodies. So the chemical sensitivity history is very, very important. And we have a lot of patients that have high chemical sensitivities. So here are some tests that I was talking to you about. There are many tests for determining what the toxic exposures have been, but these are the ones that I mostly use. And I use real-time labs urine testing for mycotoxin for patients who have Medicare, because Medicare covers this test, and therefore there's little to no out-of-pocket expense to the patient. And this test groups the mold toxins into aflatoxins. So they test for the aflatoxins, which can come from food, usually from things like nuts or from grains, and like corn, barley, oats, wheat, anything that can get stored in a moldy silos can give you aflatoxins. And they also test for gliotoxins, which are very powerful toxins for the brain. And last but not least, they test for trichothecenes, which are the derivatives of the toxin derivatives made by black mold or Stachybotrys. And that is the source for sarin gas. One of those trichothecenes makes a gas called sarin gas that most people have heard about with Gulf War illness and with the Iraq War. Great Plains Lab is another lab that I use, and Great Plains Lab does a test for mycotoxin, and some insurances cover it. A lot of times it's an out-of-pocket expense, but they divide the toxins into the toxins that come from aspergillus, which are aflatoxin, and ochratoxin and gliotoxin, and the toxins that come from the penicillium, which can also be those three toxins, the especially the ochratoxin, and the toxins that come from the trichothecenes, which are called like roridin and verrucarin and zearalenone. So Great Plains subdivides it more, and they do a different testing technique, but I think that they're both sensitive and specific. So I use either one depending on the patient's ability to acquire the testing through either their own payment or through Medicare. Great Plains, on the other hand, also has testing for the other environmental toxins that I'm very concerned about. So they have metabolite testing for different petroleum derivatives, for plastic, for styrofoam derivatives, for pesticides, including permethrins, which are the ones that come in the flea and tick collars that we put a lot of times on our pets. They also test for benzene, which if anyone studied chemistry or any of the engineering degrees and had to take a lot of chemistry courses, they were probably exposed to a lot of benzene. And very interestingly, they test for Agent Orange. People who are old enough to remember Vietnam remember hearing a lot about Agent Orange and about the deaths of the veterans that came back from Vietnam due to Agent Orange. However, Agent Orange is in the United States, and it was used at the same time that it was used in Vietnam. It was used in farms in the United States to exfoliate the leaves from trees. And interestingly and sadly, we're finding it in the urine of our patients who are not old enough to have even been born during the Vietnam War. So either they got it from their father or mother who may have been in Vietnam, or they got it from their water supply here in the United States. And the Environmental Working Group, EWG, has a list online that's accessible to anybody where you can check your tap water and you can see what kind of contaminants are in your tap water. And I strongly urge people to check that and to try to get their water as clean as possible. The Great Plains urine testing also tests for rubber derivatives, also for dry cleaning derivatives. And last but not least, it tests for a chemical known as tiglioglycine, which is a marker of mitochondrial toxicity. Many of our patients have elevations in their tiglioglycine levels. And so far, we've only done Great Plains environmental toxin testing in about 150 patients, but so far 100% of them have shown one type of toxin or another. Great Plains also has another separate test, which is for glyphosate, which is also known as Roundup, which we've been trying to get out of our country for a long time, and it's illegal in other countries in the world, but glyphosate is also another test that's available. I usually don't order it separately, except if the patient really wants to know, because it can be treated pretty much in the same way that we treat the other toxins. So Great Plains also has fecal, hair, RBC, urine, and whole blood testing of metals. It also has an organic acid test, which can reveal the microbial influences on organic acids. So some of these environmental toxins will cause different bacteria to overgrow, and also poor eating habits, which feed the pathogenic bacteria, can cause organic acids to be produced. And it can then predict whether you're more susceptible to Candida and more susceptible to Clostridium, such as Clostridium difficile, which causes that severe diarrhea that used to be only found in the hospitals, but now it can be found even in the community. It can be community acquired. Next, Genova is another lab that does stool and GI testing, and they have functional scores that they provide now, which tell you about digestion, about inflammation and immune response, and what your gut microbiome looks like. So they show you whether you have enough good bacteria versus how much pathogenic bacteria you have, and how much secretory IgA, which is indicative of having pathogenic bacteria. They also test for your pancreatic function or your digestive function by checking for pancreatic elastase. And they also check for N-butyrate and short chain fatty acids, which tell you what your digestion of fats and protein are like. And therefore, they indicate whether you need to include more fiber in your diet. They also test for fecal fats, because if you don't have enough lipase in your digestion, if your pancreas isn't making enough lipase, or if the food you're eating is overwhelming the amount of lipase that your pancreas makes, then you'll have fecal fat showing up in the stool. You'll have a stool that may float, and that can be corrected. So I always try to look for things that I can correct. They also test for ova and parasites, including PCR testing, which is more accurate. And the ova and parasite testing is amazing, because even in patients who haven't traveled to other countries, sometimes we find parasites in them. And last but not least, the Genova stool test, test for methanogen dysbiosis, which can lower your immune response. So that can also cause slowing of the GI tract or gastroparesis, and it can also damage your immune barrier to the gut, therefore causing leaky gut. Then we have another test, Microgen Labs, which I actually ordered on a patient yesterday. Microgen Labs tests various body fluids for bacteria using PCR testing. So the regular way that bacteria are tested for in places like Quest and LabCorp is that they actually plate the urine or the stool or the phlegm, the sputum, or any other body fluid, and they put it on a plate, and they watch for colonies to grow. Well, with these probes that they do PCR testing with, you can get a much more accurate count, because you can have a much lower bacterial count and still find it in the urine. And especially in patients with interstitial cystitis, this is an invaluable test. And I actually found out about this lab from a patient. So getting back to the regular labs, you can do the urine and blood heavy metals in both Quest and LabCorp. So if you're resource limited and your insurance covers lab testing, then you can get those tests done through Quest or LabCorp. They both have reliable urine and blood heavy metals. The difference is that you have to, in many places, in many environmental medicine practices, not in my practice, but in many environmental medicine practices, they give a precipitating agent so that you get some kind of chelating agent to show the urine, to have the urine show more of the heavy metals. In our practice, we haven't done that, and we have still discovered arsenic, mercury, lead in our patients, even without having to do precipitation tests. So if I'm really concerned about it and need a precipitation test, I may refer a patient out to a practitioner that does precipitation testing so that we can find that out. But if someone has amalgams in their urine, or if they have some kind of prosthesis that may involve heavy metals, there's a very interesting case of an orthopedist who lives in Alaska, and he will be presenting at the next environmental medicine conference. And he had exposure to cobalt. He developed what's called cobaltism and actually became kind of psychotic. They have a Netflix documentary about it. And this was caused by him getting 2 hips that were cobalt on chrome. So some prostheses have heavy metals in them, so they can cause heavy metal toxicity. So that's part of getting a good environmental history, because if you find out that somebody has prosthetics, you have to try to find out what kind of prosthetics they have, especially if it's like a total knee replacement or a total hip replacement or a total shoulder replacement. Next, you have doctor's data that also tests for heavy metals, and they test for your nutritional status, so they can tell you all your vitamin levels, which are, again, are also done. Many of the vitamins are done by Quest and LabCorp, so I usually do them through the patient's insurance. Doctor's data also has environmental testing for different environmental exposures and gastrointestinal health and toxic elements. And I also use a lab called Microbiology DX, because a lot of the mold patients have something called biofilm or marcons, and the Microbiology DX specializes in nasal cultures that tell us about this, and therefore this can be treated. So this is just my recommendations for my patients. These are standard general recommendations for how to treat mycotoxins. I use usually bulletproof or any other type of coconut charcoal if the patient is not allergic to charcoal, and I start them on 1 capsule a day, 2 hours apart from food or other medications. However, if a patient is on medication that is an essential prescription medication, such as a chemotherapy, such as a heart medicine, I'm very careful with their charcoal, because charcoal not as badly as things like clay or cholestyramine, they are binders, so they can drop the levels of those medications. So the other alternative is to use sweating, and always in addition to that, you have to give something like glutathione or NAC. So I recommend sweating to patients that have medications that may be affected by the charcoal or the other sequestrants, because I don't want to create a bigger problem than we started off with. Okay. The cholestyramine I try not to use, because it's very, very constipating, and it has to be taken very frequently during the day, up to 4 times a day. And Dr. Shoemaker always recommends compounded cholestyramine, which can start running quite a bit of money, because the prescription cholestyramines have either an artificial sweetener in them, in the form that's cholestyramine light, or they have the high fructose corn syrup, which a lot of our patients respond badly to. So I usually use charcoal, or I use sweating in addition to glutathione. And the glutathione, I start off just with 1 drop daily and advance by 1 drop as tolerated. Sometimes patients have to advance by 1 drop a month. They can't even advance by 1 drop daily. So, and other patients can go up to 2 teaspoons daily and have no problems whatsoever. So it's very individual. I look at it as being an analytic chemistry. When you do quantitative analysis in chemistry, you actually get a compound and then you try to figure out what that compound is made of. Well, in this case, we have a patient and we have to find out what toxins are in that patient. So this is part of the treatment for that. And then the mitochondrial detox regimen, this is the one that I use. I got this directly from the Great Plains Lab recommendations. Most of our patients are already on CoQ10, but we try to titrate them to 300 milligrams daily. I always try to take it in divided doses between breakfast and lunch, because if you take CoQ10 too late at night, it can make you stay awake for too long. And then we add NAD, and there's actually an NAD that's 20 milligrams. They used to make it in 25 milligrams. Now they have one that's 20 milligrams that's available online. And we use L-carnitine, or you can use acetyl L-carnitine, and you can start at 500 milligrams and then build it up to 1,000 milligrams. And in order to not give more medications, I usually ask people to start eating foods that are high in vitamin B2. So you can look it up on World's Healthiest Foods. It's a website, and World's Healthiest Foods will tell you the nutrient content of any of foods. So you can look up, if you want to look up vitamin B2, you can look up vitamin B2. In the next one, if you want to look up vitamin B3, look up vitamin B3. And why do I avoid giving people vitamin B3 as a pill, or as a capsule, or as a tablet? Even the slow release, quote unquote, flush free vitamin B3 can give you a lot of flushing and a lot of sweating and a lot of redness that patients become very concerned about. So I try to encourage people to look up World's Healthiest Foods, and that also gives you a chance to eat better. And I also add biotin to this regimen, but I only add it once a week. Be careful with biotin, because there have been reports of people with too high vitamin B7, which is biotin, or if the levels are too high, instead of helping your hair and your nails, it can start falling, your hair can start falling out. So I try to limit the biotin intake to 5 milligrams weekly. And then vitamin E, 200 units daily. But if bruising develops, then I back off and use less, because sometimes omega-3 comes with vitamin E added to it, and omega-3 also can cause bruising and bleeding. So I try to be careful with vitamin E, because there are conditions known as hypervitaminosis E, where you can actually start depositing too much vitamin E in your liver, and you can have elevations in your liver function test from that. So what do I do after I start this regimen? I wait at least 7 months, and sometimes even a year, to recheck the environmental toxin test. The reason being that, first, the treatment, I start very slowly to develop, tolerance, so that patients will be able to tolerate these regimens. And these chemicals don't come out of your body that quickly. So I don't spend patients' money by repeating the test very, very frequently. I wait at least 7 months because it takes at least a month to rev up to a tolerable detox regimen. And again, in addition to the mitochondrial detox regimen, I encourage patients to sweat. And I don't encourage sauna in most patients, especially the ones with autonomic dysfunction. Sauna pulls out a lot of fluid all at once. And especially here in South Florida, it's very easy to sweat. You can sweat even inside your house just by keeping the windows open. So I don't encourage people to sweat profusely unless you're relatively healthy. And if you're relatively healthy, you usually don't need all this detox regimen. And the environmental toxins also require glutathione or NAC to get pulled out of the mitochondria and out of the cell. So again, I encourage patients to start with 1 drop daily and try to advance by 1 drop daily as tolerated, but even 1 drop weekly, 1 drop every 2 weeks, it's a cumulative effect. So if you're able to tolerate it, don't get discouraged if you can only tolerate 1/8 of a tablet of NAC. Some patients, that's the detox protocol that they're able to tolerate, and they still end up being able to detox. So please don't get discouraged. Give yourself whatever time is necessary. You probably didn't get the toxin exposure overnight, so it takes time to take it out of your system. There are multiple resources available online for whole food detox of heavy metals. I like to use this type of regimen because, again, I don't use chelation. There are ongoing studies at Mount Sinai Hospital in Miami Beach using chelation to try to get heavy metals out of patients that have heavy metals causing peripheral vascular disease, which was TACT1, TACT1. And now he's doing coronary artery disease patients in the TAC2 trial. And he's a specialist. He has an NIH-funded trial. And there are other practitioners that are very familiar with heavy metal chelation and have been doing it for a long time. I don't feel that I have that kind of expertise, so I try to use things like cilantro, things like blueberries, things like garlic or lemon water or chlorella. Those will still chelate out heavy metals. The only heavy metal that I'll refer to a nephrologist will be lead. If someone has a high lead concentration, I will refer to a nephrologist to get the chelation done on those patients, because that is very important to get out as quickly as possible. As I mentioned before, Genova stool testing also gives you natural, quote unquote, kill agent sensitivity and antibiotic sensitivity for pathogenic bacteria and yeast. So in some patients, I treat them with natural kill agents such as plant tannins, such as oregano oil, such as berberine. I rarely use uva ursi because it's very toxic and it can be damaging to the liver. And we already have enough things on board that can be damaging to the liver. And Genova will give a panel that shows if somebody is at risk for inflammatory bowel disease, and those patients I refer directly to gastroenterology. I don't try to correct their inflammatory bowel disease by using natural kill agents or antibiotics or anything like that. I try to get rid of whatever environmental toxins may be contributing to their inflammatory bowel disease. But if I suspect that they have ulcerative colitis or Crohn's colitis, I refer them to gastroenterology. And for the MARCONs, also patients sometimes have MRSA, MRSA in their nasal swab that I send to Microbiology DX. And I treat the Marcons with either BEG spray, which is Bactroban, or mupirocin, combined with EDTA and gentamicin, which is made into a nasal spray. And if they have MRSA, then I use Bactroban ointment applied to their nose. This is a study that I've been doing with our medical students who have been documenting the results of our mold toxin patients. So 209 patients at the time that we made up the poster, we had 209 patients. Now we're up to about 240. And they had ochratoxin. OTA is ochratoxin. Ochratoxin was the most common toxin that we found, and that comes from Aspergillus usually, sometimes from Penicillium. Next was aflatoxin and gliotoxin. So our patients had quite a bit of mold toxicity. 92% of our patients had mold toxicity. And some of the patients had not been provoked with glutathione. Dr. Jeanette Hope, who is a mold specialist that I've learned a lot from, and I try to follow a lot of her protocols, she has found in her practice that patients who don't have mold toxin but have a significant mold exposure history, she actually repeats the test with a glutathione or an NAC, but usually a glutathione provocation before. So at least a couple of weeks of taking glutathione before retesting, and that increases the deposition of mold toxin in the urine. And we've repeated the mold toxin on some patients that were negative initially, and once we gave them glutathione before, they've also come out positive. And upcoming will be other students are working on finding what the prevalence is of the environmental toxins, but because I review all the labs when they come in, I know that 100% of the patients' labs that I've reviewed have shown some type of environmental toxin. So the prevalence for females or for women to have mold exposure was a little bit lower than in men, which is weird because most of our patients are women. So we're going to keep adding to the denominator. We'll keep adding patients to the study, and this will probably reverse this finding, but we thought it was interesting. And of note, this poster was accepted for presentation. We presented it last year at the American Academy of Environmental Medicine, and it was presented and published by the CEME at the Kiran Patel Nova Southeastern University College of Medicine student research. So it's in their publication for this year. And now it's just been accepted for presentation at the Florida Medical Association. So the word, we're trying to get the word out there for all physicians to know about the prevalence of these illnesses in patients, so that hopefully you'll be able to have these tests done by your primary care physicians even before we see you or while we're seeing you. I'm happy to have as many physicians involved as possible. So the next time we meet, I'll have the information hopefully in poster form for the environmental toxins, but it is quite prevalent in our population. So these are my references. You're welcome to look them up. You know, the references date all the way back to Dr. Ray's initial books that were written in 1994 and 1995, and the exposure history dates all the way back to the first chemical sensitivity volume 1 dates all the way back to 1992. So again, this information's been out there, and I'm grateful that we were able to access it for you. If you need any of these references, you can text me, you can email me. I'll be happy to give you any information that I have. This is a very interesting book, Optimum Environments for Optimum Health and Creativity, Designing and Building a Healthy Home or Office. This is a book that was also written by Dr. Bill Ray in 2002, and it's out of print, but the Environmental Health Center in Dallas has copies of it. It's sadly being gouged on the internet. So it used to be sold for $30, and now the prices are really, really high. So if anybody wants a copy of it, please reach out to the Environmental Health Center in Dallas. And if you have any questions that I haven't answered, please reach out to the American Academy of Environmental Medicine. I'm the CME chair now until October, and the amount of information that I've gathered from attending their conferences is unbelievable. So I thank you for listening, and I'm sorry that I may have rambled on. Thanks for being here.
Thank you, Dr. Ray. Learning about the environmental approach to ME/CFS was incredibly illuminating and very practical. Next, we'll be taking an intermission, and we will return to continue the webinar at 1:45. Please feel free to stay if you'd like. We will have a rotating slideshow during the intermission with some information and resources from both the INIM and ME Action Network. Thank you, and see you at 1:45. Welcome back. I will now be introducing you to one of the nurse practitioners at the Institute for Neuro-Immune Medicine, Irina Rozenfeld. Irina Rozenfeld is a board-certified nurse practitioner committed to the health of her patients. She obtained a second master's degree in integrative medicine at George Washington University. Irina's focus at the INIM includes ME/CFS, chronic infections, vector-borne illnesses, metabolic syndrome, chronic pain, environmental issues, detoxification, and autoimmune diseases. I will now hand it over to Irina.
Hi, good afternoon. I hope everyone have good lunch, because I'm gonna talk about nutrition. And my colleagues really good preview, and I will be just continue on everything what already was said. What is emerging from medicine now is that myalgic encephalomyelitis, chronic fatigue syndrome, considered part of the spectrum of diseases, and it involves many systems in the body. There is a different hypothesis. There is a microbiome involved, there is a chronic infection, immune activation, many organs affected by the illness when we see these patients. Therefore, my focus of my presentation highlight current evidence related to chronic fatigue syndrome pathogenesis and nutrition, and show and discuss any available biomarkers, nutritional interventions, as well as treatments, which can be potential nutritional have interference in this illness. So as we discussed in previous presentations, etiology of ME/CFS is unknown, and there is a different etiological subgroups. This is a new study from 2018 from Germany, and that picture, I want you all to look on this picture and see many patients remember they can report this post-infectious onset of illness. But then we have this schematic where there is immune activation, which we can report with biomarkers. We have significant group of patients. We have autonomic dysfunction, and there is symptoms of central nervous system dysfunction. There is the brain hyperperfusion, hypometabolism, and neuroinflammation. And I want you to look on the left side of this picture. There is a metabolic alteration, which kind of fed by all the pathogenic problems, and they all affect metabolic alteration. What is missing from this schematic, and which in a big part Dr. Ray discussed, it was detoxification problem. As much as the metabolic alteration, detoxification problems affect patient status. And as you see on this picture, that the circle, TCA cycle, it's a Krebs cycle. This is how our body produces energy. We are taking macro elements, macronutrients, carbohydrates, fat, and protein. From any food you eat, you're taking these macronutrients. Then you need add micronutrients, which is the vitamins and minerals, and then all together it's moving through this Krebs cycle, producing energy for you, for each cell in the body. And from the research and literature review, what we're doing, first of all, chronic fatigue syndrome is not different from any another chronic illness. Any chronic condition put nutritional health at risk. But particularly in CFS, Dr. Bested and Dr. Marshall in Canada, they in 2015 published a study, and they have statistics that majority of the patients with ME/CFS have unmet healthcare needs and moderate to severe food insecurity. There is estimated 42 to 33%, from 42 to 33%, that patients with chronic fatigue syndrome also has comorbid anxiety and depression, which can contribute to problem with food intake. And in general, individuals with ME/CFS usually have healthier lifestyle, but however, in one study, 70% have, it's shown that 70% of participants in a study have unhealthy fat, fruit, and vegetables intake, and almost 95 had unhealthy fiber intake. And fat, there is a healthy fat, which is really important for our metabolism, and unhealthy intake affect your quality of life. Now, fibromyalgia, I found this data and I found it interesting that we can correlate food intake with some of the symptoms. For example, fibromyalgia is the most common comorbidities in ME/CFS, and that sometimes exacerbation of fibromyalgia may be related to high carbohydrate intake. In patients with obesity and fibromyalgia, symptom severity is higher. The patient with fibromyalgia found to be more sensitive to food which decrease nitric oxide. Nitric oxide in a body helping with releasing pressure and kind of delaying the blood vessels. But nitric oxide synthase, it's an enzyme which destroys nitric oxide, and it's actually induce the pain. Sometimes food with histamine may trigger inflammation-related pain. So calorie is different. Calorie from cookie is different from calorie from raspberry. It's a sugar, but it's gonna be used in the body differently. Your microbiome will take care of sugar content from raspberry, but it will not handle well cookie. And here I wanna kind of fall back on what Dr. Vera was saying. The functional approach is very important in nutritional deficiencies. When we evaluate each patient and doing it very, very personalized medicine style, we can evaluate and find out where your nutrition, why, what happened, when, and where the correct pathway for nutrient to be absorbed and digested and used, not going in the right pathway. So first of all, the food what we eat can have low nutrient density because of their practices, because of their industrial agricultural practices and synthetic fertilizers. Our food sometimes is not organic most of the time, and it comes in a store when it's still not ripened, it's green and getting to the customer, not really collecting everything from the soil, because soil can be poor and not having all the minerals it's supposed to have. And then this fruit and vegetable may not even spend enough time under the sun to get all the richness and density of nutrients. Patients very frequently develop food sensitivities because of their additional components in the food. And sometimes in our population, a patient with chronic fatigue, we have polypharmacy. Patient may be taking a lot of different medication. And this is called drug-induced nutrient deficiency. You may not have hypovitaminosis. You may not have nutrition deficiency because of your constitution, but if you take particular medication, those medication contribute for you losing these particular enzymes. For example, if you're taking statins, your CoQ10 level will be low, and a low level of CoQ10 contribute to muscle pain. So as Dr. A mentioned, environmental toxicity is really important. First of all, some metals, heavy metals, some elements will again interfere with your digestion and maybe just interfere on the level of intestinal tract, but it also in your detoxification pathways, which we have phases of detoxification in the liver, phase 1 and phase 2, everything what you eat goes through liver, and liver making it lipid soluble to eliminate with the stool, or water soluble to eliminate through the kidney with urine. But that process of detoxification in the liver requires significant amount of vitamins and glutathione and healthy lipids and the proteins. It's all chemical, it's almost like a chemical plant. And again, the mycotoxin, the mold, and some pathogens, even potential pathogen in your gut can contribute to low-grade endotoxemia, increased intestinal permeability. And what happens if you have all these small bowel overgrowth and this endotoxemia, not normal microbiome and environment in your gut will interfere with your body's ability to absorb appropriate vitamins and minerals for your body to function. So solution, I'm gonna start with easy one, the easy and old one sent by Hippocrates. So making your food your medicine. It sounds it's easy, but it's not, because we have the food, it's involved when we're choosing our food, when we get our habits of what we're eating. It's a neuroendocrine behavioral system. It's actually very, very not simple solution. But we start from here, and you understand healthy diet should be really good for you, but unhealthy diet, and the picture is very different, kind of brownish in a color. So it's good to remember, yellow and brown may be not good for you. What happens when you have this oxidative stress, and it's actually a lot of sugar. We for many years talk about fat a lot, but sugar is not better than fat. And sometimes, in those picture on the right, a lot of time we eating something fat-free with a real increased content of carbohydrates, and that sugar actually pro-inflammatory. So sugar and some unhealthy fat will contribute to oxidative stress and increase in pro-inflammatory molecules. And that what it does, it changes your macrophage, which can be in mitochondria M1 and M2. So it's, I don't want to go to big details, but it's changing them from antiviral, anti-tumor protectors to immunosuppressive M2 macrophages. So we, in our institute, we have a lot of new, very special laboratory tests. We like to do metabolomic study on each patient because I strongly believe that nutritional status is very, very personal. We cannot go with one size fit everyone. And this is why some of our patients, and my patient, you already went through all this very specific test when we collect your urine and we collect your dry urine and frozen urine, and kind of, because we measure metabolites. Sometimes in the body, just measuring serum level of vitamin may not be indicative of what actually happening in the body. Because of homeostasis, your body is very smart. It will pull minerals, it will pull some molecules out of bones, out of the muscles to keep this homeostasis in the normal levels in the blood. This is why we sometimes tends to do more study, more detailed, and measure your metabolites of vitamins and your oxidative capacity. And I want to mention that at this time, they have ability to measure, to study genomics and nutrigenomics. Some nutritionists do these studies, and we doing it also. The difference between genetics and genomics, genetics, it's a study of, we have genetic diseases well known where a disease affects whole gene or part of the chromosome. Genomics, this is a study of this single nucleotide polymorphism. You maybe have 23andMe done, you heard about these letters, which usually is single nucleotide polymorphism measured in a basis, and we have the names for the letters A, T, C, G. That is not mutation, what you see on 23andMe, it's a variance. Because of this variance, we are different. We have different color of the eyes, we have different color of the hair, we have different characteristics. This is variance, and we don't treat them as an illness. However, for nutrition, recently, and this is really new studies, and it's coming every year, so many, and it's hard to incorporate. It's different. You not always can see exact things from ancestry tests, like we call them edutainment tests. You should have tests from validated laboratory for this purpose. And it gives us opportunity to look in your predisposition, how you process enzymes, how you process proteins, how you, if you have any variance in absorption of vitamins, and kind of to look in your genetic makeup to see what supplements, what vitamins you need because of this variance. So I got interested in nutrition because we conducted study, and in that study we asked our patient, it was metabolomic study, we was studying all kind of metabolites, 45 different biomarkers, and we asked patient, wash out, do not take any supplements for 2 weeks. The 3 patients resigned from the study during the first week. They couldn't complete washout period because the symptoms worsened, and they said we cannot tolerate life without supplements we were taking. Anecdotally, after this study, the patient who were very strong and they survive and they give us the blood and they come back on their supplements and they said, they report to me right away, this is such a big difference. And I start doing this literature review, trying to find out, is any vitamin, any particular chemical is deficient in patients with chronic fatigue syndrome? And I can tell you, no, there is no such data. I cannot find one particular proven that you have chronic fatigue syndrome because you are deficient in this particular molecule. There is no such data. However, I found huge amount of literature from, I was measuring from 1994 until 2019. And there is already a couple really good quality systematic reviews where we're trying to put all these randomized trials and observation and cohort study and see what is actually missing in all these different little studies, which most of the study were studying biomarkers of nutrition or nutritional interventions and how these interventions in nutrition affect the symptoms and how it can help us to understand. And some, interestingly enough, some supplements and vitamins will come in to show an even significant difference, significant enough significance from research point of view that correlation between supplementation and relief of symptoms show really good numbers, supporting that this particular will not a chance. This is results of patient taking this antioxidant or minerals or vitamins, and it's reported as a beneficial on particular symptoms which corresponding to chronic inflammation or mitochondrial dysfunction or oxidative stress. And the supplements and vitamins, which I will see that reported as in these studies as beneficial to some symptoms. And the symptoms can be very different, from depression and fatigue level and muscle pain and general life quality. It's very heterogeneous studies, so, but it's the same supplements, the same vitamins, and kind of correlated to energy production in the body and detoxification pathways. And so this is what I see most often in all the studies as the beneficial, this nutraceutical supplement. And I'm gonna talk about each of them a little bit in details. However, I wanna give you a disclaimer. I strongly believe that vitamins in a high dose act exactly the same as a medication. It can harm. There is a reason why everything needs to be measured and prescribed individually, because it can interfere with your medications, it can interfere with, it can give you side effects. For example, I love magnesium. I prescribe magnesium for a lot of my patients, and I think it's a great mineral. But if patients have kidney function, sluggish kidney function, or even worse, kidney insufficiency, magnesium will be harmful. So this is why I am saying you have to speak with your clinician. It's great, it will be great if your clinician has functional integrative medicine approach and trained and understand vitamins and minerals, and particular herbs. Herbs has its drug in its own way. So I want to just mention a little bit. As I start with magnesium, it's an most abundant mineral in the body. It shows in research to be helpful in fibromyalgia and in chronic fatigue, for muscle pain, and of course, because it's participate in transmission on nerve impulses, it's in muscular activity and detoxification pathways. It's involved in energy production and synthesis of DNA and RNA. Selenium can be toxic. It's really important element. I measure it. It play a role in detoxification. It play a role in insulin resistance, but it has to be used very, very carefully. Zinc is necessary for functioning of different enzymes and balanced metabolism in the body. It's a cofactor for antioxidant enzymes. It's important for smell and taste. Well, anecdotally, right now with COVID-19, right, and there is a lot of literature in the zinc. All my family members who still go to work take zinc. I didn't measure their level, but they take zinc in a really small amount, and we're not gonna take it for long, just for now, because zinc reported to be helpful. But it's also good for joint pain, for immunity, for wound healing. Vitamin D. Vitamin D, it's not even vitamin, it's like a hormone, and it's really important in autoimmune disorders and many in insulin resistance and in cardiovascular. And again, this is it's supporting many health problems. And of course, the most important in intestines and bone health. Vitamin C, you will be surprised, but because I measure that with all the food available and fruits and vegetables, I do have patients in United States with vitamin C deficiency. And by the way, we are not synthesizing vitamin C in our body. Compared to rodents, rodents can make their own vitamin C. We can't. We have to obtain it from food, and it's really important vitamin as an antioxidant and supporting our immunity. It's important for synthesis of collagen, and it's histamine inhibitor. Finding that right now we have some subset of patients with mast cell activation. Vitamin C is really helpful to address this problem. Vitamin B, I put here on the slide vitamin B complex because there is a number of vitamins, and I can tell you where it's really hard to pick. Slide is small. B1 is, but I put this as to support my point. Vitamin B1 is supporting conversion of blood sugar to the glucose, to the energy in the Krebs cycle. And it's important for synthesis of neurotransmitter acetylcholine. Vitamin B3 is a part of that NADH when it's vitamin synthesized by converting tryptophan to niacin, and then it plays a role in 200 chemical reactions in the body. And vitamin B12, it's a growth factor, practically affecting metabolism of each cell, especially those of gastrointestinal tract, bone marrow, and nervous tissue. And you can see why this is important in our illness, because almost in all of this pathway in chronic fatigue syndrome, we see some symptoms related to these pathways. Fish oil reported, omega-3 reported as a helpful in chronic fatigue with alleviating the symptoms. And because it decreases inflammatory signaling and metabolic consequences of chronic illness. Again, CoQ10 and NADH. In some study, it shows significant difference in fatigue symptoms when patient taking CoQ10 and NADH. So CoQ10 is found naturally in every cell in the body. Its primary role is an intermediate of the electron transport system in mitochondria. And it's necessary for cellular respiration and ATP production. ATP is our gas, it's a fuel for the cells. So that being said, again, I want to just stress this. I didn't do it on purpose, but somehow when I put all this data from research, that particular supplements which participate in detoxification and energy production, we all were beneficial in symptoms control and chronic fatigue. So back to NADH, this is a reduced form of coenzyme bind, and it utilized in the production of energy. And NADH is necessary to oxidate all foodstuff, fat, sugar, amino acid into ATP, which is our bioenergy. Vitamin E, Dr. Ray mentioned vitamin E. I want to say that you have to be careful. There is a side effects of big dose, and not every patient can take vitamin E for different reasons. It's important fat-soluble antioxidant, and it's supporting stability of cellular membranes by preventing free radicals damage. D-ribose reported as a helpful. It's actually ribose it's a sugar monosaccharide, and it's a structural backbone of DNA and RNA. So particular vitamins need ribose in some cellular, to build in important cellular compounds, including mitochondria, you need ribose. There is amino acid. I put here a couple examples that when we need particular amino acid are essential, we not produce them in the body, so we have to eat protein to help body to make and to get these amino acids. Like tryptophan is an essential amino acid. It's supporting nitrogen balance in adult, and it helps grow in infants. And tryptophan contribute to niacin, and which is essential to creating the neurotransmitter serotonin. Taurine is conditionally essential amino acid. Humans can synthesize taurine from methionine and cysteine, the same like we synthesize glutathione, which is a major antioxidant and major supporter for detoxification. We do prescribe it in our clinic, but you actually produce it in each of your cells in the body, but you need enough cysteine to produce enough glutathione. So in some individuals not able to make enough, and then we have to take it as a nutraceutical. Being so, I'm trying to point that not necessarily everything should come from the nutraceuticals and the pills. You can make your choice and change you from sick care to health care and choose the right side of this refrigerator. But sometimes with our patient, we go somewhere in the middle, and I don't believe that only on the left side answer somewhere in the middle where there is a little bit of green and color, and then something we're gonna take in a supplement form. It's not easy, but if we're gonna do the same things, we're gonna have the same results. And I like the Shakespeare quote, our bodies are all gardens, for which our wheels are our gardeners. And gardeners have really hard job to do, because our habits related to our food intake the most difficult to change. My reference most very new, I was trying to pull literature from the recent years, the recent 5 years. And I want you, before I say thank you and goodbye, I want you to look on these colors on this slide. There is red and blue and purple. Through the thousands of years of agricultural changes, we have white potatoes and we have sweet fruits, and a lot of everything in the food modified to be more palatable. But in reality, a little bit of bitter herbs really good for your digestion. and every day you have to take blackberry, blueberry, raspberry, something with a color. The purple potato and purple carrots is really good for you. That purple color comes from phytonutrients, and it's very, very healthy for you. And it's tastier than pills, and bon appetit.
Thank you, Irina. Learning about nutrition as a therapeutic approach in patients with ME/CFS was very educational and valuable. Our last speaker this afternoon is Dr. Travis Craddock. Dr. Craddock applies computational systems biology and biophysics methods towards the purpose of identifying novel treatments for complex chronic illnesses involving neuroinflammation. His current research activities are biophysics of neuroinflammatory, neurodegenerative diseases such as Alzheimer's, Parkinson's, ME/CFS, and GWI. Without further ado, I will hand it over to Dr. Travis Craddock.
Okay. Today I'm going to be talking to you about the potential role of eye and ear, nose, and throat mucus proteins and how they may contribute to or exacerbate the symptoms of ME/CFS. First of all, I'd like to thank our funding providers. Most of the funding that we have received from this have come from grants to study Gulf War illness as well as ME/CFS. Primarily, the Gulf War grants are from the Department of Defense, while the ME/CFS grants have come from the National Institutes of Health. All of the computer simulations that we do are on the supercomputer down at the University of Miami. I'd also like to say that without the entire team at the INIM, this kind of work wouldn't be possible. We form a small subgroup of this team, the Clinical Systems Biology group, and we're made up of staff, volunteers, as well as students. I would like to thank them as well for their continued work on these projects. I don't think I need to go over this for this audience, but ME/CFS is a chronic multi-symptom disorder characterized primarily by persistent fatigue lasting 6 months or more. Many people have this. You know, it's a great economic burden as well as a burden on those that have the illness as well as their family members. And we need to find treatments for this. So we're coming at this with the hope of treatment and improvement in people's lives. Now, I want to go back and talk about a study that the INIM published late last year. It was looking at single nucleotide polymorphisms in ME/CFS. So this was a study in which staff and students at the INIM recruited participants to undergo genetic testing through 23andMe and to donate their genetic analysis to the INIM for further analysis. When we did this, the hope was to see if there was any sort of common genetic predispositions in people with ME/CFS which may contribute to the illness. Now, when we did this study, we did it fairly naively. We used a reference database that wasn't the best reference database to use. So going back and looking at the changes that we found in the ME/CFS population compared to these references, we went and looked at a different set of references, one known as the 1000 genome. And one thing that we found, or at least that I found that I thought was quite interesting, was changes in mucus proteins within individuals with ME/CFS. And for the most part, the thing that kept catching my eye was this mucus 19 protein here. And it had a very high frequency for some of these changes. So upwards of 77 to 80% of individuals that underwent this genome-wide association study were found to have changes in this mucus 19 protein. And when we ran it through what's known as the CAD score, it tells you how deleterious these mutations can be. This one here in particular was very, very deleterious. It's within the top 0.03% of changes that are of deleterious nature. And what it is it's that the mucus protein is misformed. Okay, it's not being created properly. It's actually stopping prematurely. So the entire protein itself is not being made. Only roughly a third of the protein is actually being made, which leads me to believe that it may be a dysfunctional protein overall. And that's in addition to some of these other proteins, these mucus proteins, mucus 16 and mucus 22, which mucus 16 at least has within the top 6%, whereas this mucus 22 protein is within the top 30%. But these are also somewhat deleterious with changes within the amino acid sequence of the protein. So this got me thinking, what could happen? What would changes in mucus proteins, how could that contribute somehow to ME/CFS symptomatology or exacerbation or whatnot? So I started digging a little further, and we found, I looked at where these mucuses are generally expressed. And for the most part, these three mucus proteins are found in the airways and eyes. So in your nose, and your respiratory tract, in the upper respiratory tract, as well as in the eyes. And the role of these things is to provide a protective barrier against chemicals and invading pathogens such as viruses, bacteria, molds, or anything of that regard, from getting in contact with the underlying layer of skin within the nose, within the eye, and within that upper respiratory tract. So I started digging a little bit further. So is there something in ME/CFS that is common in the nose and the eye? And there's a body of work by Jim Vera-Nunez out of Georgetown University that shows that the majority of subjects with chronic fatigue syndrome complain of something called a refractory rhinitis, which is an inflammation of the nasal cavity. They're looking at a range of roughly somewhere between 66 and 80% of individuals with ME/CFS complain of this. And that seemed to me to kind of align up with the findings of the mucus 19 protein, that there's roughly 77, roughly around 80% of individuals have that change in the genetic sequence. Now, the studies by Jim Vera-Nunez, which were actually pointed out to me by a blog post by Court Johnson on Health Rising, it shows that this rhinitis, which is sometimes caused by allergies, Dr. Vera-Nunez found that it was actually a low likelihood of being caused by this common source of rhinitis. So it wasn't allergies. It wasn't due to a certain immune response from eosinophils. It wasn't due to chronic infection or chronic infectious sinusitis or other immunodeficiencies. And he didn't find the same immune markers that he would expect to come from this allergic response. So he didn't find elevation of cytokines IL-8 or cytokines of tumor necrosis factor alpha. And he said that Th2 lymphocyte and mast cell mechanisms are unlikely causes of this rhinitis in CFS, but they don't know what is the cause of it. And so I thought it was quite interesting that maybe it has to do with this dysfunctional mucus layer that may be prevalent in individuals with ME/CFS. So I have this hypothesis that mutations or variants in the ME/CFS nasal mucin or nasal mucus can result in a compromised protective barrier. So the idea is that in typical mucus barrier, you have this very thick layer. You have this outer layer that is exposed to pathogens or irritants, your molds, your viruses, your bacteria, your chemicals or whatnot. And then you have this outer layer of gel mucus, which is where mucus 19 would be found. And what it does is it prevents those pathogens from getting close to the skin layer of the nose and or the eye. And then you have this inner sterile layer of mucus, which is actually bound to the surface of the skin and anchors the gel, it provides a layer for the gel mucus to form. Now in the variant formation is that this layer out here, which would be significantly compromised due to the variant in the mucus 19 protein, would not be there. So you would have this penetration of pathogens and irritants getting much, much closer to the inner skin layer of the nose or eye. And as well, you could have problems within this inner layer in the mucus 16 or mucus 22, which could also contribute to further penetration of these irritants and pathogens. Now, if that's the case, if you have this altered mucus layer within your nose or eyes or upper respiratory tract, things that you can expect then would be an altered microbiome. So generally the types of bacteria that you would find within the nose, the populations, the variety, and the actual different types of bacteria that you would find would be different, because now the environment has changed dramatically, because you don't have the same home. You have different mucuses, you have dysfunctional mucuses, you have closer to the nasal layer, so it's going to be a warmer environment and so forth. Again, you would also have a highly irritated or sensitive nasal membrane, because you don't have the same degree of protection. And this can also result in a chronic low-grade non-allergic inflammatory response, because you're constantly being bombarded by pathogens or irritants. So it may be the case that this varied mucus layer could give rise to sensitivity to chemicals that are in the air, that individuals that didn't have that wouldn't be as sensitive to it. And overall, this irritation, this increased sensitivity, the low-grade inflammatory response could end up exacerbating the already taxed immune system of the MECF patient. So this is something that we're interested in, we wanted to look at further. Now, the nasal microbiome is something that is kind of a hot topic right now. The microbiome, if you don't know, is the genetic material of all microbes on and inside the human body. It's made up of bacteria, it's made up of fungus, like molds and so forth, protozoa, viruses, and there are different biomes depending on the different regions that you look within the body. So the one that is generally touted and most people know about when we talk about the microbiome is the gut microbiome. So what's going on in your stomach or in your digestive tract. But you can also have a distinct microbiome within the sinuses, within the nose, within the upper respiratory tract, or you have again a different microbiome within your ears or within the eye itself. Anywhere where your body is exposed to the outer environment, you can have a microbiome, and depending on the exact composition and the way that it's exposed, you're going to get different types of bacteria or viruses present in those areas. So I was looking a little bit further. There have been some studies on altered nasal microbiomes in chronic rhinitis. So this is not individuals that have ME/CFS, but it is individuals that have chronic rhinitis. So it's a chronic inflammatory response within the sinus cavities. And what you can see here, this is what it's showing is at the phylum level. So this is way up in the biological taxonomy. It's looking at what types of bacteria are present in these individuals. So here on the left, we have the chronic rhinosinusitis. We have 9 subjects, and on the right, we have the healthy individuals. And the different colored bars are representing how much proportion of the population belong to a particular phylum of bacteria. And so you can see that across subjects, within subjects, you do get some variability, and then across subjects, you get a greater degree of variability at the phylum level. If we go down further and we're looking at individual genes or individual genus levels, which is one step above the species level, we get even more variation between subjects, within subjects, and across conditions. So this is, the nasal microbiome is a very diverse environment, and trying to look at just these populations is not very informative. So you need to do a little bit more of a deep dive into analyzing these populations. So we can do things like non-metric multidimensional scaling. So what that does is it takes multiple dimensional data. So, beyond 3 dimensions, in 30 dimensions or 40 dimensions, depending on how many different measures you have. And you can collapse it down into a nice 2-dimensional picture to say how similar are these populations between individuals, within individuals, and across groups. And what was found for this chronic rhinosinusitis case is that the microbiota varied considerably and non-predictably in the individuals that had chronic rhinosinusitis, whereas within the healthy group, it's less variable. So you have more variation within subjects and between subjects when you're looking at the chronic rhinosinusitis group compared to the healthy group. So it's more variable. It changes more often in the ill group compared to the healthy group. But if you look at the diversity, so the types of bacteria that are in those groups, you get less diversity. So it varies in the how it varies between and within the group, but the types of bacteria are less diverse within the ill group. So you don't have as many different species or different genuses of bacteria within the sick group compared to the healthy group. So this is what we would expect to find within the chronic fatigue group, but this is not something that we've done yet. No one has looked at this in chronic fatigue syndrome. Or this is something we would like to do, and it's something we're exploring. We're starting to look into this more and more. But this is something that we'd probably expect to find. In addition, this is in addition to the changes in the mucus proteins. Excuse me for a moment. My apologies. Now, what this means is that if you have a compromised microbiome within the sinus cavity, this can lead to a chronic disease state. So the idea is that in the healthy core sinus microbiome, you have healthy functions that protect your nose, it keeps it in good health, and so forth. But if you have some sort of influx of pathogens or a stressor of some type, what can happen is it can force it into an altered or degraded state. This is what would happen if you're exposed to a bacterial infection or so forth. What you'd expect to happen is that the microbiome would change in respect to this influx of new pathogens. But in the healthy state, what would happen is that over time, your body would fight off that influx of pathogens and you would return back to health. Okay, so you'd have this kind of back and forth between exposure and returning to health, between the healthy microbiome and this altered temporary state. But in the case of chronic rhinosinusitis, or what I'm proposing in ME/CFS, is because of the change in the mucus layers, is that you don't stick around in this altered degraded state, but you get to this state of an inability to restore the healthy microbiome. And that may be due to the lack of proper mucus layers within the nose and so forth. And so now you're stuck in this chronic disease state, which allows you to be sensitive to incoming viruses or pathogens or chemicals. And it just makes the nasal environment not as capable of maintaining that healthy behavior. Now, the idea is what we'd want to do is somehow develop some sort of therapy that could drive this system back towards the healthy sinus microbiome to help alleviate some of those symptoms and maybe lessen a lot of the chronic fatigue symptoms and that are associated with, that may be derived from this altered microbiome or this altered mucus state within the nose. Now, this is a little bit technical. So this is the general host immune response to pathogens within the nose. You can see it's quite complicated. It involves the pathogen coming in and it irritates the epithelial layer of the cell. And in doing so, that triggers a host of immune responses that can be propagated within the blood. So this is what I'm proposing, how this change in the nasal microenvironment might affect overall ME/CFS symptomatology. So if you have changes in the nasal microenvironment of chronic low-grade inflammation. This can propagate into the blood, which would then extend systemically throughout the system and could flare up other ME/CFS symptoms via bloodborne changes in immunity. Now, if we take that and we simplify it a little bit by making it into a logic model, we get something like this. And this is something that we have developed to simulate the environment within the nose or the eye, where you have a mucus layer protecting the body from infection from a pathogen influx. So in this kind of logic model, we can take that and start to simulate the effects of what would happen if we compromised the mucus layer and allowed a pathogen influx to allow infection to occur. Now, due to the complexity of this system, it's capable of supporting multiple behaviors. And this is something that's been kind of a theme within our work, is that the complexity of the overall immune system can allow multiple homeostatic behaviors, even in the absence of dysfunction within the system. So simulating this immune response to pathogen influx across a mucus layer, we find multiple stable states. One is typical health, which here is this one with all whites and zeros. And we get two alternate states. And the thing that I find quite interesting is we have one here where we're actually getting cytokine signalings being turned up. So we have IL-2, IL-6 being increased, IL-4 and IL-10 being decreased, as well as shift towards innate immunity. But then even in the absence of those cytokine signals, we still have this state where it's kind of shifted towards innate immune cell activation. And what I'm proposing is that you have this one that's this active inflammatory state, and then you have this other one that might be a primed inflammatory state. And in the ill model, what we suspect maybe is that you're kind of in this primed state until you get exposed to some sort of chemical or irritant or another pathogen, and you can flip over to the exacerbated state and then back. But to flip back to health is quite difficult because the mucin barrier is compromised and it doesn't allow for that to take place. Likewise, your nasal microbiome is compromised or altered compared to typical health, and therefore it's constantly contributing to this system. One thing I'd like to point out here is it talks about overactivation down here in this one state of NK cells, or natural killer cells. And the work of Dr. Klimas and Dr. Fletcher has shown that in ME/CFS patients that you have a dysfunctional NK cell response. And so that's not something that's currently in our model, but something that we can work in here. And we expect it to actually exacerbate this problem even more. So this would be the typical healthy response. We have to add in and see what would happen in the case of the common dysfunctions that we would see in the ME/CFS patient. Now, one thing I would like to point out is that we are mimicking that behavior that Dr. Vera-Nunez had found within the ME/CF patients of no change in IL-8 and no change in TNF-alpha, even though you have this inflammatory response going on within the system. So this is kind of a promising description of some of his results, and I'm hoping to work with him and try and develop this model more. Now, just as a final thing, I'm saying how this could potentially lead to systemic problems by activating an immune response within the blood across the nasal epithelial layer. But Nancy had pointed out to me a while ago when we were talking about Parkinson's disease, that one way to get directly into the brain is up the olfactory tract. There's innervation from the olfactory bulb of the brain that innervates directly into the nose, so that it allows you to smell and whatnot. And in this case, it could allow direct access to the brain via the olfactory bulb. And due to the lack of a protective layer, as well as the altered nasal microbiome, we might have not only pollutants like chemical irritants, but also bacteria or viruses that are allowed to traverse up that that olfactory tract and get penetration into the brain much more easily, leading to neuroinflammation, maybe contributing to causes such as brain fog or any of the other neuroinflammatory components or symptoms that are associated with ME/CFS. So again, this is only a hypothesis and it's something that we're exploring, but considering the integrative nature of today's talks and talking about the roles of molds, the roles of microbiomes, the roles of irritants and pollutants, I just thought it was a good supplement to those earlier talks, because this provides one potential linking mechanism which links both the genetic components of ME/CFS to the environmental components to the actual underlying inflammatory causes that we suspect are underlying ME/CFS symptomatology. Future work, we would like to perform further analysis to determine if this genetic predisposition to mucus dysfunction is actually there in ME/CFS. So we would like to use more stringent measures of genetic assays. So not just using 23andMe, but more RNA sequencing or direct genotyping with more advanced methods. We'd also like to examine the nasal microbiome of the ME/CF patient to see if there's changes in diversity and variation, which we see in chronic rhinosinusitis, or something completely different. Maybe due to ME/CFS, it might be a completely different environment to chronic rhinosinusitis on its own. We'd like to analyze the composition, consistency, and production of mucus and tears within the ME/CFS patient, determine if there's dysfunction within those protective barriers. As well, it might be something that we could do for a diagnostic. If this is something that's highly prevalent in ME/CFS, it may be something as simple as a nasal swab could help to provide a diagnostic test to see if you're at risk for developing ME/CFS or if you have ME/CFS. Finally, we'd like to improve the integrative model of the mucosal immune response to not only provide a greater ability for hypothesis generation, but also to generate treatments. So not only simply to produce saline washes of the nose to change the microbiome or to change the mucosal production, but also maybe in combination with immune therapy or with hormone therapy eventually, or changes in corticosteroids, because that's usually the treatment for chronic rhinosinusitis. But putting these things in combination may provide for an added treatment or to reduce or even remove the chronic rhinosinusitis associated with ME/CFS. And with that, I would like to say thank you very much and move on to the question period of the conference. So thank you very much.
Great. Thank you, Dr. Craddock, for your presentation. That was incredibly fascinating. And thank you again to our speakers, nurse practitioner Irina Rozenfeld and doctors Maria Vera-Nunez, Irma Ray, and Travis Craddock for taking time out of your day to speak in this webinar. We really appreciate it. And I just also want to mention before we get to the Q&As, the recording will be available on our website and on our YouTube channel as well. So stay tuned for those. And just a reminder to our attendees, you can use the Q&A box in your webinar control panel to submit your questions. Please write out to which presenter they are addressed to. Anna will start it off with a couple questions that came in.
Hello, everyone. Thank you so much for participating in this webinar. Looks like we have some questions that came in and some of the panelists have already kind of taken over. So the first one I'm going to ask is directed to Dr. Ray. And it says, is it a mistake to self-treat with glutathione with no doctor supervision? I'm taking a liposomal form that comes in a gel capsule, but I noticed that Dr. Ray is mentioning the liquid form. Is that the best?
So I would say that if you're tolerating the gel form, it's fine to continue to take the gel form. The only problem with taking medications on your own without getting some of the lab testing done, as Irina pointed out in other substances, glutathione will not just pull out mold toxin from your cells, but it will also pull out all the other environmental toxins from your cells. So it may get to the point where you actually feel worse with taking the glutathione. That's why I many times introduce either the sweating or a binder first, so that we bind whatever's in the blood, because when you use the glutathione, you're actually pulling toxic substances out of their storage areas. Your body tries to store them so that they don't hurt you so much. And then now they're being pulled out into your circulation. So you may see more systemic side effects of the toxins when you take glutathione on its own. But if you're tolerating it without worsening side effects, you can take it, but I recommend testing.
Thank you, Dr. Ray, for that. I noticed that some of the panelists have already started answering some of the questions, but to be frank, I'm not sure if everyone can see the responses. So I'm going to ask a question, and if everybody can see it, the answer, then we'll just move on. This question says, is there any evidence that the ketogenic diet could help maybe a subgroup of patients? What are the risks?
I can try to answer. Ketogenic diet can be extremely helpful for patients with Alzheimer's disease, with any brain complaints, brain issue, but ketogenic diet, can be very dangerous for kidney. And in general, it's not the most easiest diet to undertake by yourself. It needs to be supervised. One of those diets which needs to be supervised because the high protein content and high fat content, it's actually you need to pick appropriate fat, appropriate proteins, and kind of know where to stop because it can harm. It's not easy even for practitioners to undertake ketogenic diet properly, particularly to understand where do not harm, because high protein level will be not really easy for kidneys. And again, it has benefits, definitely, but it needs to be administered with a good nutritionist or clinicians who understand how to do it right.
Thank you, Irina, for responding to that. Is there another panelist that would like to add to that? If no, okay, then we're going to move on.
Real quick for me, there's a little risk of hypoglycemia as well, because if someone with high insulin levels started out too fast on that, they could drop their blood sugar.
Yeah.
Thank you, Dr. Klimas. Okay, this question is directed to Dr. Craddock. Dr. Craddock, could your findings possibly explain sensitivity to light, sound, and smells?
Definitely to smells. I can say that because you would be more sensitive to the chemicals that you're inhaling, and all smells are chemicals. I know that Dr. Baranik has talked about changes in nerve innervation due to the chronic rhinitis, and so that can also, at least in the nose, can change the way that smells and such are perceived. So definitely smells. The light and the ear, the sound in the ear, possibly. I don't know as much about them. I have done most of my focuses on the nasal cavity. I'm not sure what the role of the mucus is in the perception of light within the eye, or the perception of sound within the ear. It's a possibility though, and something that I'll take as something to look into. Thank you.
Thank you, Dr. Craddock. The next question is for Dr. Klimas. Are we patients more susceptible to a severe COVID experience?
So I actually have a YouTube video on this. If you want to Google it, you can find it. Because the point is probably yes. You tend to turn on your inflammatory buttons very easily. So if you had the COVID infection, you're probably at higher risk for the cytokine-mediated parts of that. Now, I don't know that. I'm making that assumption based on what I know about ME/CFS. We have had a few patients that have developed COVID. Most of them lived in New York, one in Italy, and they actually did okay. So they had a flu-like illness. We had one in the hospital. We had an older patient in the hospital up in Boston. So, but they all made it. The bad ones made it. Everyone else, the local patients we've had with COVID have all been just flu-like illnesses. They have very severe. So on one hand, I'm saying, yeah, you should worry. Take extra precautions not to get it, because yeah, you could have a more serious course. But then again, some of the things that, if you are patients, you're doing to try to improve your immunity and your antiviral function and that type of thing might be protective.
Thank you,
May
Dr.
I answer that too?
Absolutely, Dr. Ray.
Yes, so I've had one patient of the patients that I treat that has developed COVID, and she made it through. And just this week, they were reporting how the vitamin D levels probably have something to do with the morbidity and mortality of COVID. So I'm very happy that we've worked so hard for so many years to try to keep your vitamin D levels up because it seems to be protective to some degree of COVID.
Thank you, Dr. Ray. The next question is for Dr. Rozenfeld. Can you recommend some healthy foods?
Oh, yes. Yes,
Hey,
I
it's
can.
your favorite subject, of course.
Yes. That all my patients, probably from the day one, recommended to start fiber supplements. They're all different. I don't really want you to take cellulose fiber supplements. I want a natural fiber made out of root vegetables as a pill. I understand that nobody gonna eat beets, but this fiber, and I'm based my observation from the evidence, and the fiber is usually not, and it's not only chronic fatigue patients. In general, 90%, even higher than in chronic fatigue patients, 90% of population does not eat enough fiber. And in some illnesses like comorbidities in chronic fatigue, the fiber is helpful. I would like to follow functional medicine model where it's not just what you eat, it's also important what you remove. And in this conversation, when I start with a patient, I start diary, watch what you eat and see how you feel after that. Then for some patients, removing grains will be great relief from joint pain. Particularly people in rheumatoid arthritis, there is a studies where there is a correlation between rheumatoid arthritis and gluten sensitivity. So if you, that sensitive person, and you will notice that you eat milk products, you have particular symptoms, something causing you bloating, something causing you nausea, just document, make a note if you don't remember, and just pay attention. For patient, it's important when you eat, what you eat, how it's prepared. If you have, I need to actually, it's an old medical advice. Sometimes it's better to know patient than to know the disease of the patient. I think Dr. Ray, Dr. Klimas, Dr. Vera-Nunez will agree with me. We really have to know our patient, and the best our advices will be when we know our patient really close. So if you have irritable bowel syndrome, with all goodness of raw vegetables, I would not recommend you to eat raw vegetables because it's not going to be healthy food for you. You're going to have more bloating, more symptoms, and more problems. Your vegetables probably needs to be baked or boiled. It's really big difference that healthy foods. Of course, if you can have your fish oil from the fish, but it must be a lot of fish, and it's not fish coming from Thailand or China. It must be maybe probably better from some North Sea, somewhere close to North Pole, and less heavy metals in it. For some patients, it's really healthy. The diets by itself and a healthy diets, it's very strange things. I have a patient who was kind of when I talk with the patient, and they prefer to eat brown rice, right? Because it's a healthy option, but amount of arsenic in the brown rice way higher than in a white rice, and practically rice all over the world, it's really hard to find organic rice which doesn't have arsenic because of the industrial, how it's agriculture works right now. So this is really strange topic about healthy food. Yes, the picture, I was trying to show the picture of this pizza crust, and obviously you're gonna eat pizza once in a while, but if it's only what you eat, it will not be healthy. If you eat it sometimes, and it will be okay. And diet, something there is right now with mimicking diet and fasting diet, and for some patients who has obesity and they're waiting for 12, 14 hours between the meal and giving themselves this option, do not eat, it's probably healthy. And I sometimes reviewing surveys from my patient, and I see that my patient have first food intake at 3 p.m. in the afternoon, and in the morning already feeling weak and fatigued. Where's the energy supposed to come? It's like physics. Where's the energy come if you didn't eat whole day? So healthy diet, it must be really personalized again. I'm really personalized medicine person, but you have to review your symptoms. You have to monitor how you feel after your food, what you eat, and then make differences. But I can say for sure, add some healthy fibers. And again, if you want to get some food good from the food, even this example, carrots is good for you, but if you want to get beta carotene out of carrots, your carrots needs to come with some kind of fat because it's a lipid soluble vitamin, and you need to eat it with some kind of mayonnaise. I don't know how to say it, but there is a lot of healthy food. Practically most of the food is healthy. We make it unhealthy when we cook it wrong way, or we eat it too much, I guess. Did I answer the question?
I think you did an excellent job. Thank you for going into so much detail, Irina. This next question is for Dr. Craddock. Did you find any other frequent SNP besides the MUC gene? How about gut mucus protein?
No, not in the initial analysis. We didn't find changes in any other mucus proteins besides the 3 that I listed on the presentation. I'm working with Dr. Nathanson, though, to continue the analysis because when we initially did it, we had about 383 subjects within that study, and now we have, I believe, over 1,000. So we need to do another analysis to check what the findings are with the updated data sets.
Thank you, Dr. Craddock. Somebody's asking if there's anything that can help brain fog. Which provider would like to answer?
I'll go for it, Ms. Nancy. But any one of us could do it. But brain fog is coming from so many different things, so it's not an easy one answer covers it thing. But one of the things that can come from is oxidative stress. We do know with beautiful science, beautiful imaging data, that ME/CFS patients have increased lactic acid in their brain and oxidative stress, depleted antioxidants. And once you get that going, you're going to have inflammation. It's going to affect blood flow. It certainly affects mitochondrial function and energy. So one thing you can focus on is trying to get your brain's antioxidants back into balance. There are different ways to do that. There are different strategies. One very direct strategy is to take advantage of that olfactory bulb that Travis was talking about and spray glutathione up your nose. It's a compounded a medication. It needs to be prepared by a pharmacist, but we've seen some fairly immediate benefit from that. Dr. Shangu is doing a study using NAC, a very inexpensive oral antioxidant, with good data to suggest it's crossing the blood-brain barrier and reversing some of those effects I just described. So antioxidant approaches are one way. Another important thing is blood flow. And the very earliest researchers in ME/CFS showed decreased blood flow to the brain, particularly in response to cognitive tasks. So there's a practical thing you can do, just like you pace when you're doing exercise, you can pace when you're doing cognitive effort. That is, take breaks, sit back, close your eyes back, better yet, put your head down and your feet up and let some perfusion happen, because blood flow is an issue. But there's also some pharmacologic approaches to that. I'll stop there and let anybody else answer the question.
I'm just going to say ditto that it depends on the cause of the brain fog. There isn't one specific thing that can clear brain fog, and I believe that you should always have the diagnostic testing to try to figure out what may be contributing to your brain fog.
Thank you, Dr. Ray and Dr. Klimas, for answering that question. Dr. Klimas, you mentioned in your response items that could cross the blood-brain barrier. So we have a question about which anti-inflammatories would cross the blood-brain barrier. Dr. Ray, Dr. Klimas, would either one of you be able to answer that question?
I was chatting away and I didn't unmute.
Sure. Pretty much all the non-steroidal anti-inflammatories cross your blood-brain barrier. Everything from ibuprofen to indomethacin and in between. And steroids cross your blood-brain barrier. Medical cannabis crosses your blood-brain barrier, and so does low-dose naltrexone. So those are all the anti-inflammatories that I know that cross the blood-brain barrier. Which one would be helpful would be up to your specific provider, and they all have side effects. So you have to weigh the risk versus benefit of using an anti-inflammatory. That's why I like low-dose naltrexone and a medical cannabis, because they're pretty low on the list in terms of side effects.
There's nutraceuticals that cross as well that are anti-inflammatory, such as curcumin, but particularly nanocurcumin. That's one that's formulated to cross the blood-brain barrier. Omega-3 is an anti-inflammatory that inhibits tumor necrosis factor, which is one of the things that's wrong in ME/CFS. So it's a nice targetable thing to do. Omega-3 is pretty healthy, yet there's not too many contraindications for that one. I know, Irina, you probably have another dozen or more to talk about.
Irina Rozenfeld had to unfortunately leave us to go to another meeting.
Okay. Too bad, because this is her cup of tea as well. Because nutraceutical approaches can be very low toxicity, high yield in this area. But the thing I said before about antioxidants in the brain, oxidative stress causes brain inflammation. So going after oxidative stress is a very reasonable approach. So what, NAC, the intranasal glutathione, liposomal glutathione, another very good approach. There's many choices.
So then as a follow-up, Dr. Klimas, how much NAC do the study subjects have to take to see a result?
Well, that's the focus of his next study. They just picked a dose in the first study and it worked, but it was a high dose. They were using 900 milligrams twice a day of a Canadian product that's is an effervescent one that is mixed into water. But they did completely reverse to normal the imaging changes that are due to oxidative stress. So that was very impressive and very nice study. They just got funded to do the next one, which is a dose finding study to see if you have to go that high to get the benefit.
Thank you, Dr. Klimas. Okay, this individual seems to be asking a question that seems to be a common question for our patients and our attendees. Says, beyond trying meditation and other de-stressing techniques, this individual's cortisol has been sky high for years and they can't get it down. Any thoughts or ideas or recommendations?
Hey, Irma, what do you say? Because I know this person. We've been working on this. So you got any ideas for us? There are some nutraceuticals that are focused on that. Again.
Yes. You can use phosphatidylserine.
Yeah, that's a good one.
However, I haven't had much benefit with asking patients to use it. So since all the environmental toxins can usually initially cause a high cortisol level, plus number one environmental toxin is lack of sleep, I strongly recommend that people with a high cortisol level get a sleep evaluation to see if that's contributing to their high cortisol levels.
That's a good idea. I like that idea. Yeah, there are some herbs that are that inhibit cortisol production. You know, most chronic fatigue patients, it's quite the opposite, that they have low cortisol production. So you got to be careful not to generalize from this conversation that it might be good for you to try to reduce your cortisol, because some people have very blunted adrenal access and they can have quite low cortisol levels. So this is where personalized medicine is a good thing. Got to know yourself before you go tearing off trying to do something. But I'll keep thinking, and next time we see each other, we'll be talking about that. Go personal fast.
Thank you,
Nancy,
Dr.
I
Klimas.
remember that Gordon Broderick, the very first CFS-ME conference that I was a part of when we were still at the University of Miami, he postulated that initially the cortisol levels would be high. And then from adrenal fatigue, the cortisol levels would start dropping.
Yeah, and I think all of our data in long-term patients would suggest that that's true. And of course, we have so little data from people early in their disease process because they have trouble accessing care in time to be even studied during the early phase of their illness.
Thank you, Dr. Klimas and Dr. Ray. Dr. Craddock, we have some individuals who are interested in participating in your research. Is there any way for individuals to become involved?
Not at this time. We are seeking funding for the nasal microbiome study. That's something that we're currently looking for. In future, if we do get funding for that, then we'd probably have an announcement through the INIM clinic. I believe that the INIM clinic usually does have announcements for most of their studies.
And that's correct, but we are doing one study that's that you mentioned, we got a COVID-related pause. We were just starting the postmenopausal women and men's reboot study when we got stopped by the current situation. But as quick as we're allowed to, those studies are FDA approved. We have some, not perfect funding, but enough to get started. And we will be starting those studies. So if you're interested in that, just go to our webpage. Keep an eye on our webpage. All this stuff is on our webpage. And when we're recruiting, we're using the webpage to communicate with people.
Thank you, Dr. Klimas. So we actually only have time for one more question, and I see many individuals are interested in getting information as to how they can actually be seen in our clinic. So I'm going to let Dr. Klimas, our director, speak more on this.
Yeah, so well, I saw some of the questions you're asking about costs and things like that. We're always trying to expand our clinical services. You can imagine that we're very busy, and we often feel a bit overwhelmed with the number of patients that need expert care and are not finding the experts that they need. First, just about costs. We accept Medicare, but only Medicare. Otherwise we're cash pay. We're not expensive in the way other private clinics are because we set our price at Medicare. That meant that if you were going out of network, you'd be responsible for whatever your out-of-network fees are, but I think that we would be considered very reasonably priced. We did that on purpose. Also, NOVA has a sliding scale if you're willing to fill out all their how much income do you have forms, all the way down to free. So all of that is true in our clinic. We follow all those same things. So that's one thing. To get into our clinic, the first thing you need to do is call and say, hey, I want to be in the clinic. If we don't have an appointment, and we have a bit of a waiting list right now, at least get on the waiting list. And if you would express that you're flexible, particularly you local people that can, just come on down if there's a cancellation. Sometimes you can jump off the waiting list because we're going to fill our clinic. We're going to try to make all our spots fill if we have cancellations. One of the questions was about telehealth and whether or not telehealth was going to make it possible for us to do more out-of-state care. It's certainly our intention. We would love to do that. That would be fantastic. First, for our existing out-of-state patients, it's such a pain to do the follow-up visits under the constrictions we have from Medicare and state laws and so on. But this is one thing you can thank COVID for. There's just been a great liberalization about what we consider an appointment and what is considered telehealth versus a phone consult and so on. So these things are changing every single day. I can't hardly keep up. But our university is aware that we do a lot of out-of-state care. Until now, they have not been able to provide us with a telehealth option. But now that we have the in-state telehealth, we're trying to get the out-of-state telehealth approved. If you hear that lovely little noise, that's my 6-week-old brand new grandbaby who's lying on my lap while I'm chatting with you. She's the best. Anyway, I think that's what I know about that. The point is, yes, we take new patients. We are very full. And we'll try to do the best we can and fill every spot we have. But the other thing is we're committed to medical education, providing providers from other states and counties, whatever information we can provide to them. We do a lot of sidewalk consultation with people's doctors, even if we're not their doctors. So we just try the best we can without, totally breaking the law. But the best thing for us is to get more staffing. And so we're always working on that as well to try to get additional providers so we can provide more care. We have a brand new provider in our clinic. Denise is a nurse practitioner that joined us just recently. She got stopped by COVID too, right before she started establishing her own practice within our practice. But she'll be coming in with gangbusters as soon as we're allowed to start seeing face-to-face patients again. And maybe sooner. Okay, that's all I got.
Thank you, Dr. Klimas. We're reaching the end of our schedule, and unfortunately, that's all the questions we can take. I want to thank all of our speakers again for participating, and I would like to thank ME Action Network for their support in this webinar and for being one of the many strong assets for the ME/CFS community. During the intermission, we had a couple of their slides rolling through, discussing some of their initiatives and their efforts. I'm going to hand it over for a few minutes to ME Action Network's Florida chapter, Dawn Holt and Laura Buckholtz, to discuss ME Action and how to get involved.
Thank you, Sarah. Forgive me if my internet comes in and out. It's been a bit of a weak connection. It's raining over where I am. But thank you all. This has been such a great presentation with such good information. I wish all doctors had this kind of love and information about ME/CFS, but they don't, and that's why we need to continue to advocate, right? So we'll tell you a little bit about ME Action. Can I get the next slide, Sarah? So let me tell you about ourselves. I'm Laura Buckholtz. I'm the Florida State Organizer for ME Action. My husband has had moderate ME for about 8 years. So I work with volunteers across the state on all different advocacy projects for Florida. I joined ME Action actually when I stumbled upon Jen Brea's TED Talk, and that's when me and my husband quite suddenly understood that we weren't alone in this disease. So when I realized the scope of the, I call them injustices basically, that we encounter with our clinical care and our research and everything with ME, I wanted to jump in and make as big a difference as I could. So I volunteered with ME Action, and that was about 3 years ago, and I formed the Florida group, and we've done a bunch of projects in the state of Florida that I'm really proud of. I've met a ton of amazing advocates, worked with them on a continual basis, and one is here to speak with me too, Dawn Holt. So I'll let you introduce yourself, Dawn.
Thank you, Laura. Hi, everyone. I'm Dawn Holt, and I've had ME for 21 years. My world was devastated when I got a virus, and I never recovered. I've been significantly affected by ME. For 10 of those years, I've been primarily home or bedbound. Through the years, I've been involved when able with ME/CFS support groups, awareness, and fundraising events in South Florida. Then in 2018, I found ME Action after seeing the film Unrest. I joined ME Action Florida Facebook group and had the privilege of meeting Laura and started volunteering for ME Action with her, working on various projects and providing support to people with ME. I'm the lead advocate and contact in South Florida, with most everything I do being done from my bed. I have a great desire to do what I'm able to help our ME community, whether it be support, education, fundraising, or advocacy. I'm extremely proud to be involved and represent ME through such an incredible organization. And I'm also extremely fortunate to be a longtime patient of this world-class clinic. So, about ME Action. Next slide, please. You might be asking who we are. Well, ME Action is an international organization that develops and supports a network of country affiliates, affinity groups, city, state, regional, and other local chapters, and individual advocates. We are people with ME, caregivers, family members, and allies. And our mission at ME Action is to build a global movement to fight for recognition, education, and research so that one day all people with ME will have access to compassionate and effective care. I'll hand it back over to Laura now. Next slide, please. Laura, are you there?
Well, I needed to hit unmute first. So if you want to meet other advocates like us or check out what we're up to, ME Action has a bunch of different groups that gather primarily on Facebook. So for instance, I'm the admin on the Florida State Facebook group, and there's a group for each of the 50 states. Florida is one of the 9 official state chapters, one of the states that's a little more active. But there's a national group and there's group for countries all across the globe. The other type of group that's really interesting are the affinity and the interest groups. These are great because you can connect with others based on things like your age or your severity of ME. I know there's one just for nurses, there's one just for parents. And for instance, I'm in a group that is just for caregivers of people with ME. And it's been a really incredible experience to find others who understand, because I know when you go out there into the real world, you don't find a lot of understanding like I do inside that group. So I encourage you to go find your people. You might make some wonderful connections, and you can find all the different groups at meaction.net/groups. So next slide, please. So if being an advocate sounds nice to you, and you want to join in, one way you can after you find us on Facebook, Millions Missing is this week. And you have probably heard of this, but if you don't know, Millions Missing is ME Action's global movement, basically to raise awareness and to push for our rights as people with ME. So it happens every year in May. The ME community generally comes together in person, in in-person gatherings, but not this year. This year we have a virtual action, and every year there's usually a message. And this year is actually about the coronavirus. So, I mean, us, we, the people with ME, unfortunately know what can happen after you catch a bad virus. So this message is, it's important to us that it hits close to home, that the COVID-19 pandemic will cause the number of people with ME and other chronic illnesses to grow. So we're calling for an urgent response to mitigate this oncoming crisis. Research now, educate healthcare workers now. But what we're doing is we're basically spreading this message across social media. So if you want to join us, there's still time. You can post to social now. We've been basically sharing our personal stories about ME on social media, wherever you are, Facebook or Twitter, or Instagram, and hashtag it Millions Missing. Or you can go, search the hashtag and see what other people have posted. And then just one other thing that we've been doing for this awareness week in Millions Missing, ME Action had a virtual event and they recorded it. It did actually feature Dr. Klimas. And you can find that on ME Action's Facebook page. And that's something else you can share on social if you want to. So that about does it. And I just wanted to say that I love carrying the banner for people with ME. And I hope that you come and check us out and maybe join in some of the advocacy efforts. So thank you for your time. Dawn?
Thank you, Laura. And we'd like to thank Sarah for all your hard work in bringing this webinar to us. A heartfelt thank you also to Dr. Klimas for championing for the ME community for all these years. And a big thank you to all the speakers for sharing your expert knowledge, and to everyone at INM for all the things you do for ME. We greatly appreciate you. So thank you very much.
Thank you, Dawn and Laura, and to ME Action Network for being an incredible resource and for creating such a welcoming virtual community. Lastly, I just want to mention you can donate to the INIM by following the link you see on the screen. You can also find the link in the follow-up email that you will receive in the coming days. Just be sure to select the Institute for Neuro-Immune Medicine when making your donation. Your gift, no matter the amount, will help ensure that the INIM will continue to be a vital resource for our community. Also, you can connect with us on Facebook, Twitter, YouTube, and on our website, nova.edu/NIM. You can also subscribe to the INIM by clicking on the subscribe button on our website to stay current on the Institute's upcoming events, any webinars that we're going to be having, news updates, and much more. Thank you everyone for attending. Be safe and have a wonderful day.